Hi everyone. Hopefully you took a little break before you start this PowerPoint. This is a pretty lengthy one. There's a lot of new information on here. The anatomy portion of some of these structures can be a little bit confusing, so we're just going to kind of keep it broad topic. But when we get into a lot of the importance of how to document these things and why it is so important and why it can be so emergent, that's when we'll really get into the importance of these things. How many times can I say importance, guys? Okay, so we're going to be starting with our placenta first. We're going to talk about some anatomy associated with the placenta and how the placenta can appear different depending on the patient. So the placenta is a really unique organ in the sense that it's the only organ that we actually just grow and develop in pregnancy. So yeah, we're growing and developing a baby, but we're literally growing an entire additional organ to keep that baby supported. So we have this very particular communication between the mom and the baby, and that's all going to be done through this placenta. So we're going to have a fetal component or a fetal aspect, and then we're going to have a maternal component. So how do we exchange all of this important material and information between the mom and the baby, and how do we make sure that it is working in a cohesive collaboration? So our fetal component, so the aspect of the placenta that's going to focus mainly on communication with the baby, is going to be formed by that chorion frondosum, like we learned really early on this semester. This is going to be when that fetal surface of the placenta is our chorionic plate. So we're really going to be in that primitive stage when that placenta is developing. We still probably have that yolk sac at that stage. The chorionic aspect is going to be what is mainly in communication with the baby when it becomes the placenta. So you have the placenta that is actually adhered to the mom. So it's going to be adhered to that uterine tissue, and that's going to be our maternal component. So this is going to be when we have all of that endometrial tissue that underwent decidulization, that's going to be how this placenta kind of sticks to that uterine tissue and has that communication with the mom. So thinking on that really early aspect, now our basal plate is going to be what forms the maternal surface of that placenta. Now the baby isn't actually touching the placenta, so when we say the fetal aspect or the fetal surface of the placenta, we're talking about the side of the placenta that is closest to the amniotic fluid and the baby. When we're talking about the maternal component, we're talking about the outward aspect of the placenta, so the portion of the placenta that is in communication directly touching that uterine tissue. So also our maternal component of this, we have a lot of blood vessels that come from the mom's uterine tissue to go in and supply that placenta. The baby doesn't give us any vessels that are going to go and supply that placenta, right? So we have to rely on the mom's anatomy to feed that placenta and to make sure that that placenta is staying nice and healthy. So we have a lot of maternal blood that's circulating through all of those placental spaces, all of that placental tissue. Now, the placental spaces or the intervillous spaces are going to be where the exchange between the mom and the baby happens. So the exchange of blood, the exchange of nutrients, all of that is going to happen in those little pockets and in those little intervillous spaces of the placenta. Now we can get some complications that arise with that because that is kind of the last stop of communication between the mom and the baby. So if the mom's blood doesn't match up with the baby's blood, that's where we run into complications. If we have a blood clot that kind of forms in those intervillous spaces, that's where we run into some complications. So we'll talk about that a little bit later on, but on a very functional level, that is where we want to be focusing in terms of communication between the mom and the baby, those intervillous spaces. Now, the placenta itself, as we know, is mainly to communicate with the mom and the baby, and that is going to be directly related to the survival of that baby. So if you do not have a functioning placenta, the chances of that baby surviving are very, very low. So we need to make sure that the placenta is functioning properly and that we're staying as healthy as possible. Now, the placenta does something very interesting in the sense of it starts to work harder when it's exposed to poor maternal exposures or environments. So basically, if the mom is a smoker, if the mom is a drinker, if the mom lives in a toxic environment in terms of chemicals or fumes or radiation, the placenta is going to say, oh my God, I got to do everything I can to protect this baby. So it's going to start working overtime. Now, that may sound like a great thing, and it is a great thing, but the bad part of that is that the longer that placenta has to work at that high capacity, the sooner it starts to die off. So now the later in pregnancy we get, this organ is saying, oh my gosh, I've been working for so long. I'm so tired. I'm really just going to kind of stop working. And that's why we don't want moms to go past 41, 42 weeks of pregnancy, because the placenta is done. It's done working. It's served its purpose, and it's saying, listen, I can't do anymore. I can't, I'm done. I'm done working. So now if you're making it work harder for that pregnancy and for that duration of the pregnancy, it's going to die sooner. So that's when we run into the risk of preterm labor and stillborn babies. So yes, it's a good thing. It protects the baby from some things that maybe we can't even control, but it is also protecting that baby from some of those environmental factors that are preventable, with the understanding that that placenta is not going to make it for the full length of the rest of that pregnancy. So here we have an embryology recap. You can kind of correlate this back to our very first PowerPoint where we were talking about the development of that first trimester pregnancy. Some of these keywords are going to be very familiar. So we just said our chorion frondosum. That's going to be the fetal aspect of where that placenta develops and how it communicates with that baby. This is going to be that trophoblastic tissue, especially when we were learning about that deciddualization and where that blastocyst is going to implant into that uterine cavity. We have our chorionic lave. That's going to be the chorionic membrane that's going to surround our gestational sac. It's typically going to be opposite of where that implantation occurs. So we have our implantation with our blastocyst, and then our placenta is going to kind of form on the opposite side of that, still within that chorion frondosum, but opposite of where that specific blastocyst burrowed into the deciddualization. And then we have our basal plate. So this is going to be everything related to our mom. So this is going to be where all of our vessels are going to come in and develop. It's going to be where it adheres to that uterine tissue. And this is going to be contiguous or continuous, kind of interchangeable term here, with the decidua basalis. So going really back to that first lecture that we had. So the function of the placenta, like we said, is dedicated to the survival of the fetus. It's going to have three main functions. One is going to be the transfer of oxygen and carbon dioxide, nutrients, and waste. Also going to be responsible for the metabolism of the baby. So this is all going to be done by the functional unit of the placenta. This is known as the coityledon. We typically have 12 to 20 per placenta, and these are kind of what give the placenta this sort of grape-like appearance in terms of its bulkiness. So usually on the maternal aspect of the placenta, we kind of see a smooth delineation between the placenta and the mom's uterine tissue. Then on the fetal aspect of the placenta, we see it kind of lobulated and not as smooth. And that's going to be because of all of those cotyledons, those functional units. So in these functional units, they are going to be responsible for saying, okay, let's get all that oxygen to the baby. Let's get rid of all that CO2. Let's give them all the nutrients and get rid of all that waste. So all of those transfer functions are going to happen because the cotyledon said for them to happen. Now, where these functions are happening is in those intervillous spaces. So between the mom and the baby, those intervillous spaces are where all of that communication is going to happen. So it's driven by the cotyledon, but it occurs in the intervillous spaces. Now, there are additional functions that are equally as important, but they're not really the main function of the placenta. That's going to be protection of that baby. So if you were to get into a car accident, you have the placenta to kind of absorb some of that shock, right? It's also going to be responsible for respiration. So it's giving that baby oxygen so that baby can practice breathing in utero. Also storage, so nutrient storage is going to occur in the placenta, and hormonal production. So the placenta itself is producing hormones throughout the pregnancy. So it's keeping that kind of equilibrium between the mom and the baby. So we need to talk about the membrane that is surrounding the placenta and why it is so important. The membrane itself is going to provide a barrier between the mom and the baby. So you're probably like, well, we just said we care about the communication. between the mom and the baby. And that is true, but we need some sort of gate, right? We need something to, if something were to happen with the mom or the baby, can we provide some sort of protection to both of them? Right? So can we kind of shut off that communication if we need to? And that's what this membrane is going to do. It's going to basically prevent the transfer of certain components or certain compounds. So basically, how do we protect that baby from drug use? Right? Well, yeah, the cotyledons are going to kind of process that out, but the membrane is basically going to be the first stop and say, nah, you're not coming in. Right? We don't need you. And then the other main thing that the membrane does is it protects the mom and the baby from differences in the blood. So we're going to learn about this as we go on through the semester, but you can have an incompatibility between blood types of the mom and the baby. So this is kind of how we keep the mom and the baby safe when they do have two different types of blood. So it's this larger barrier between the mom and the baby where, yeah, we're still allowing that exchange of oxygen, CO2, nutrients, waste, some of those smaller compounds, but then the bigger things, the bigger components that we need to keep out or keep separate from each other is going to be done so by the membrane. So this physical barrier. Now, there are certain factors that can really affect the function of the placenta. We kind of talked about them already. Maternal habits, right? Maternal environment, so smoking, poor diet, drug use, any of those things is going to make the placenta have to overcompensate for that. And like we said, we don't want that because the longer that placenta is under stress and has to work harder, it's going to have some complications with the baby and the rest of the duration of that pregnancy. So if the placenta has to continually work overtime for those maternal aspects, we're going to see placental damage. It's going to die a lot faster than it should. We could see fetal damage. We could see intrauterine demise, like we said, that stillborn baby. And then we could see a spontaneous abortion. So really just kind of for no other reason other than the fact that the placenta could not do its job because it was constantly exposed to these poor factors. So that's really kind of the only thing that we need to worry about in terms of function with the placenta. Now, there are some physical complications of placental formation that can run into other sorts of fetal complications, but we'll get there in a second. So how do we evaluate the normal placenta? So we can see it commonly, not commonly, uncommonly as early as 7 to 8 weeks. You are not definitively going to be able to say that that is a placenta on a first trimester ultrasound. Doesn't happen. So really even at 8 weeks, we could still see a yolk sac. So we're not going to be routinely evaluating the placenta that early. The placenta is going to be evaluated on the anatomy scan. So between that 18 to 24 week time frame, we're going to have a really good idea of what that placenta looks like, where it's located, any sort of variance to it, and if it looks like it's working properly. At the time of delivery, the placenta is going to kind of weigh a lot. It's a really big organ. It's going to be about 500 to 600 grams at the time of the average delivery. Typically, it's going to be disc shaped, so kind of like a frisbee. It's going to be 2 to 4 centimeters in AP diameter, so it's pretty thin for the most part. And then, like we said, we have the baby aspect, the fetal aspect, and the maternal aspect. So we have the chorionic plate and then the basal plate. The chorionic plate, the fetal aspect, is going to be closest to those fetal contents, so closest to the amniotic cavity. It's going to see, you're going to be able to see that echogenic chorionic plate along that placental border. It's going to help us to provide a division between the amniotic cavity and the maternal aspect. And then our maternal aspect, we are going to see it kind of continuous with the mom's anatomy. So we're going to see the junction of the uterine tissue versus the placental tissue, and it's going to be what is located furthest away from the amniotic cavity or the fetal contacts. So the placenta itself is going to be highly vascular, and that's going to be from all of those maternal vessels that are feeding it. So it's kind of going from the myometrium into the endometrium, or what is now the decidual tissue, and it's going to travel towards that fetal aspect, so towards the chorionic plate. It can appear kind of cyst-like, kind of Swiss cheese-like, and that's because we get these little pockets of blood flow that occur in the placenta. We'll talk about those as well. But basically, when we see anything that's looking kind of anechoic in the placenta, we want to put color on it and confirm, is it just a vessel or is it a fluid collection, which can be very common as well. So what should the texture look like? What should all of the other characteristics look like? It's going to be homogeneous, it's going to be kind of pebble gray. We see these hypoechoic areas, like we just said, they can appear anechoic. These are known as placental lakes. We'll talk about those in a little bit as well. The placenta should have smooth borders in the sense that on the maternal aspect, we see a nice clear differentiation between the myometrium and the placenta. And then on the fetal aspect, we see it a little bit more lobulated, but we don't want to see any sharp edges on the placenta. So we're going to see nice smooth lobulations on the fetal aspect. Now the thickness is going to vary with gestational age. So the further we get along and as that placenta grows, it's going to reach a certain thickness. And then once we reach a certain gestational age, so once we kind of get to that like 38, 39, 40 weeks gestation, that placenta is going to say, okay, I'm getting tired here. So it's going to kind of start to degenerate at that time. So that thickness will then start to get smaller. So as the placenta develops, it gets thicker and thicker, but then it reaches a certain age and it's like, I can't do this anymore. So now it's going to start to degenerate and become thinner. So now there are certain types of conditions that can affect the thickness of the placenta. We will learn about that as well. But basically, we don't want to see an overwhelmingly large placenta. We don't want to see a placenta that's like massive on our screen and then the baby in contrast looks much smaller in comparison. So that's going to imply to us that there's some sort of processing disorder going on with that placenta. So gestational diabetes, processing disorder, RH sensitivity, that goes back to the incompatibility of blood types. We'll learn all about that as we touch upon those topics. If you are going to measure the placenta, it's not a standard picture that we have to take for an anatomy scan, but if you're looking at it and you're thinking, it looks a little bit thick, then you want to make sure that you are doing so when your placenta is perpendicular. So you want it kind of like a femur length in a sense, like you want to see it horizontal across your screen, and then you want to be doing a direct AP measurement thickness. Sometimes we can get what is known as Braxton Hicks. You may have heard people talking about this, but these are kind of known as false contractions. They're not necessarily false in the sense that they're, it's that they're not real. It's that they're not real contractions. They're basically practice contractions. So it's your uterus starting to kind of go through that motion of contraction, and your placenta undergoes that as well. So you can actually see Braxton Hicks occurring in the placenta. Now, basically, they're not super painful for the mom, but they just feel this kind of tightening of their belly happening, tightening of the uterus happening. And when we see them in the placenta, they kind of look like a focal mass in the placenta, but all it is the placental tissue sort of kind of grouping together and starting to squeeze on itself. So here's a standard picture of what our placenta should look like. Now, in terms of location, that's going to be different for each patient. This patient is an example of an anterior placenta, because if we remember, here's our anterior anatomy, posterior anatomy, and here we see this nice, smooth, medium level echogenicity placenta. Here are our smooth lobulations of that chorionic plate, the fetal aspect. Here's our umbilical cord communicating with the placenta into the baby, and then some more smooth lobulations. Now here is kind of what those placental lakes can look like. Can't 100% confirm that that's not a vessel because we don't have color on, but they're going to look very similar, and all you have to do is just put color on to confirm it. Not necessarily a type of pathology or anything that needs to be documented specifically. So nice standard placenta. Now we can actually grade the placenta. We don't really use this, especially in the ultrasound world. This is something that is going to be used maybe by OBs, depending on how closely they use ultrasound. in their practice, but this is not something that if you're working in a radiology department or in a hospital, you're really going to be doing. You can use it. Some people do use it to help determine gestational age. This is really only going to be helpful in the sense of a woman who has not gotten any prenatal care at all. They maybe didn't even know that they were pregnant, and now they're kind of coming in last minute, and you're trying to figure out how far along that baby is. Is it safe for delivery? Is it not? So again, not using this often. It's often very inaccurate because, like we said, depending on the factors that the placenta is exposed to, can really affect how that placenta is going to work and function and look on ultrasound. So we grade it typically from 0 to 3. Basically, the further up in grading we get, the further along that gestational age is. We're looking to see, are there calcs? Are there not calcs? What do those calcs look like? Are there anything else going on in the placenta? Any areas of infarction, right? So that tissue death, as we know, older it gets, the more tissue death we're going to see. So we're going to see kind of these areas in the placenta of infarction. And that's going to be kind of similar to what it looks like in the spleen, where we can commonly see it. So not something that you're going to be responsible for doing, but definitely something that could be a registry question. Okay, so locations of the placenta are very important, and it's going to really kind of determine how you perform your anatomy exam. If we look at our two standard pictures here, we have a posterior and an anterior placenta, and there are a lot more locations that go into where it can kind of grow and develop. We could have a fundal placenta, we could have a low-lying placenta. When we get into the world of low-lying, that's where we start to get into some complications. So when we're looking at these two pictures, we're talking about anterior or posterior in reference to the mom. So here is our posterior placenta developing. Here is our anterior placenta developing. Now, when you have an anterior placenta, a lot of times moms have, or what they think they have is reduced fetal movement. So when you have this placenta that sits in the front of your belly, you're not going to be as likely to feel the kicks and the punches of the baby, the movements of the baby. When you have a posterior placenta and the baby's kind of kicking and punching, you can feel all of that a little bit more frequently and a little bit earlier than a mom who has an anterior placenta does. Now, when we have a low-lying placenta, we'll talk about this in a little bit more detail, that's when we start kind of creeping up into this area here. So low-lying in reference to the cervix. We want to make sure that the placenta is at least 2 centimeters away from that cervical opening. And we'll come back to that in a little bit. So we can have some variations or some variants of the placenta. They are typically kind of normal. We don't really worry about them too much. We don't really do anything with them. We also don't really diagnose them on ultrasound, but in the OB world, it is important to know that placental variants do exist and what they look like. So we can have extracorporeal types, and then we can have accessory types. So if we have extracorporeal types, this is talking about when we have a variation in that chorionic membrane. And basically that membrane, that large barrier, that gate to the placenta, either doesn't attach where it should or it doesn't fully attach, and that's where we get into these two types of variations. We can have a circumvallate or we can have a circummarginate. Now, if we have a circumvallate, this is when we have a really small central chorionic ring that's surrounded by a thickened amnion and chorion. So the other membranes are kind of thicker in response to the chorionic ring that's not as thick as it should be. So this can actually result in bleeding and threatened abortion. So it's not necessarily a complication in and of itself, but we can see some bleeding with this, and that can be a little bit worrisome for moms and for OBs. So a circummarginate is, again, a central attachment of the membrane without a central ring. So now we don't really have like this ring around the membrane that's kind of holding it into place, and that can kind of cause it to weaken a little bit. But for the most part, if the placenta is functioning properly and it's not really having to work overtime in response to stress, these placental variations will be okay. We can also have accessory types. This is going to be caused by abnormally early placentation. So basically the placenta is going to kind of develop too early in the pregnancy, and we can kind of get like these extras or these abnormal shapes to the placenta. So we can have a succinturate placenta, and where we have basically an accessory functional unit with a vascular connection to the main placenta. So kind of like in the spleen where you have an accessory spleen, this is kind of the same thing, an accessory placenta. So it's kind of just like another extra functional unit that's hanging out nearby the placenta, and it has a communication to the bulk of the placenta. We can have a bipartite. This is where we have a division through the placenta into two lobes, but we're still communicating with each other between the vessels and the membranes. And then you can have an annular placenta where it's a very ring-shaped placenta. So instead of being disc-shaped, it's a little bit ring-shaped. I guess we could say, when I was talking about the thickness of the placenta, we're talking about a frisbee in terms of that thickness. I guess we could say that the standard placental shape is kind of like a boomerang, where it's still kind of thin, but it's a little bit curved, right? It's that disc shape. Whereas an annular placenta would be a little bit more like that frisbee, where it's rounded and kind of just like plops right on top. So here we have our diagrams of our placental variant. So up top, the top row is going to be our accessory type, and the bottom row is going to be our extracorporeal type. Accessory type, remember, just happens early on in that pregnancy, and then the extracorporeal is when we don't have the correct relationship of the chorionic plate. So if we're looking at our accessory types up here, we don't want to look at these right now. We have our succinturate lobe. This is our accessory placenta. See a little extra functional unit over here with our vessels and communication. We still see it protected by that membrane that's surrounding all of it. And then we have our bipartite or our bilobed. We kind of just see this little division between the two, but we still have the same vascular communication, and everything is still protected by that membrane. Now, if we're looking at our bottom images here, and then an annular, it really is just going to be kind of similar to this diagram right here, but we don't have this like abnormal ring around it. So now if we're looking at our bottom pictures here, this is when we have the extracorporeal type. So we have our circumvallate, and then we have our circummarginate. So basically, if you're looking at the attachment of the placenta, that's where we're seeing some abnormalities. So we have kind of like this over-thickened amniotic and chorionic membrane surrounding that placenta on our circumvallate, and then our circummarginate, we still have kind of that abnormal attachment. So this is why we can kind of run into some of those complications with bleeding in a threatened abortion, because the attachment of it is not as cohesive as it should be, or not as reciprocal in relationship as it should be with the rest of the maternal aspect. Okay, so placental thickness, like we kind of mentioned this before, depending on the age of the baby, depending on the environment that the baby is developing in, our placental thickness is going to vary. So now we don't really want to see an increased placenta, because it can kind of lead us to think that there's something wrong going on with processing or with fetal abnormalities and anomalies. So if we see an increased placental thickness, which is greater than 5 centimeters in that AP diameter, that's going to lead us to believe that there's one of these kind of conditions going on. Now, gestational diabetes, this is something that we're going to talk about. Same thing with RH isoimmunization. This is also RH sensitivity or blood incompatibility. If there's a maternal infection that the placenta is trying to process, if there's a chorioangioma, which we'll talk about, multiple babies, so multiple gestations can have a large placenta to help supply both of those babies equally. If the mom has anemia, if there's hydrops fetalis in the baby, we'll talk about this as well, but basically that's when we have fluid accumulation in 2 or more pockets of the baby. If they have a sacrococcygeal teratoma, we will talk about that as well. If the pregnancy is a partial mole, so remember, partial mole, you can have a pregnancy developing along with that abnormal trophoblastic tissue. Any chromosomal abnormalities or abruption of the placenta. We will talk about about abruption in a second. If we have a really thin placenta, we need to worry about other things. We need to worry about IUGR, intrauterine growth restriction, diabetes pre-pregnancy. Also, any intrauterine infection, polyhydramnios, if we have way too much amniotic fluid in there, and then also preeclampsia. So that's a very concerning maternal condition that is associated with uncontrollable high blood pressure. Okay, so moving into some abnormalities that we need to be aware of with the placenta, or kind of some severe complications that we need to be aware of. Placenta previa. This is talking about an abnormally low-lying placenta where it is touching the cervical os or covering the cervical os. So when we're looking at placental location, we want to see that that placenta is at least 2 centimeters away from that cervical opening. And that's because if our placenta is too low, when we go to vaginally deliver the baby, that placenta is going to come out first, or the baby is going to put pressure on that placenta, and it's going to lead to lack of oxygen to the baby and potentially stillbirth, and then rupturing or hemorrhage for the mom. So if we have placenta previa where the placenta is either covering or too close to the cervix, it is way too severe of a complication. That mom is going to get a C-section. So kind of that's like the broad way of putting that, but we have more information on this slide here. It can be caused by low implantation of that blastocyst into the decidual tissue really early on in that first trimester. It's going to be more common in women who have had previous babies, a history of a C-section, a history of a myomectomy where they can go in and remove a fibroid, or multiple surgical abortions. So this is not talking about a medical abortion. This is talking about if you've had to have any sort of surgical intervention, and that is either DNC, DNE, any of those other invasive procedures into that uterine cavity. It can result in painless vaginal bleeding in the second and third trimesters, and this is something that can correct itself. So what does that mean? If you have a placenta that is sitting low or close to your cervix, right, or it's touching the opening of your cervical os, as the baby grows, the placenta doesn't move, right? It's not going to move away from the cervix, but what happens is as the baby grows throughout pregnancy, the uterus stretches and stretches and stretches. As it stretches, the placenta is going to stretch with it, and it's going to appear to move further away from the cervix. So you can have a low-lying placenta, which is not really considered a true previa, because basically if you are within that 2 centimeters of location between the cervical os, as your uterus grows, the placenta will move further away from it because of the stretching of the uterus. So low lying is not typically categorized into placenta previa, but it is something that you need to be aware of when you are scanning, say, an 18-week baby. You know that that baby has a lot more growing to do. So yeah, we want to document it as being within 2 centimeters of the cervix, but you understand that as the pregnancy grows and develops, it will no longer be considered a low-lying placenta. So when you're talking about a true placenta previa, we're talking about a complete or an incomplete. A complete is like, yeah, that entire placenta is sitting right along the bottom of that uterus. There's no way that as this uterus stretches, it's going to get pulled in any sort of direction. Incomplete, kind of close to that in the sense that like it's partially covering the internal os, but it's not fully covering the whole aspect of the cervix. So what do these variations look like? Here we have our normal placenta, nice and fundal right at the top here. There's no way that we need to be worried about that. Then when we have our marginal or our partial, we're a little bit, so actually I don't really like this picture. A partial, this is kind of like a low lying. A partial is going to be like here. If our placenta was seated there at the cervical os. And then a complete, I mean, the entire thing is covering the cervix. So of course that mom is going to get a C-section. Okay, moving into placental abruption. So this is when we actually have a placenta that separates or detaches from the myometrium. This is very, very concerning. This is something that needs immediate medical attention. And this is something that can oftentimes be hard to diagnose. So there are some risk factors for having an abruption. This is any mom who has hypertension. So whether it be kind of situational high blood pressure or whether it be preeclampsia, doesn't really matter. We run the risk of having this separation. Advanced maternal age as well. So the older that uterus is, the less likely it is to have a good, strong, solid connection with the placenta. Also multiparity. So again, if you've had a lot of pregnancies before, you're kind of weakening your uterine tissue, your uterine muscularity. Maternal vascular disease, again, you don't have the vessels supplying it as well. Any sort of cigarette smoker or drug use is going to kind of weaken that relationship. And then any fibroids too. I mean, depending on how large they are, depending on where they're located, they're going to kind of serve as like an obstacle, right? So if you need to have this strong connection between the placenta and the myometrium, but instead you have kind of this like weird fibroid sitting there, well, the connection is going to kind of have to go around that. And then that's going to be a possibility for separation later on in the pregnancy. It's going to result in abdominal pain with or without vaginal bleeding. Now, that's going to be a very big clinical piece to this. So depending on the location of the separation, depending on the classification of the separation as well, bleeding is always going to accumulate in the retroplacental region. So behind the placenta, between the placenta and the myometrium, we're always going to see blood accumulating. Now, clinically, whether or not you have that vaginal bleeding is going to determine your classification. So we can either have a concealed placental abruption or an external placental abruption. And that name is going to give it away. So if it's concealed, it means that you don't have any vaginal bleeding happening. So this means that the bleeding is going to be confined to the uterine cavity, and this means that the detachment of the placenta from the uterus is total. So there's no communication between the placenta and the myometrium, and you're actually going to get like this little pocket of hemorrhaging because of it. Now, when you have an external classification, this means that only one aspect of the placenta detached, but the other aspect of it is still attached. So it kind of makes this valley that allows the blood to kind of travel through down and out. So this is where we get the external vaginal bleeding in these patients. Now, you would think that the vaginal bleeding classification is going to be a little bit more serious, but it's not. It's actually less severe because you still have a portion of that placenta that is attached. Now, if you look at the difference between the two classifications, let's look at our external first. So this border right up here is still attached, right? And then this border, this region, all detached. So that is what kind of made this valley to allow that hemorrhaging to come out vaginally. And then if we look at our concealed, well, it's not attached anywhere, right? The whole length of the placenta is detached from the mom. So it's kind of creating this pocket that's allowing for the blood to accumulate. Now, this is more severe because we don't have any communication between the placenta and the myometrium. And then we also kind of have it undiagnosed, right? Because you don't clinically have that vaginal bleeding like you do with the external. So placental abruption, very, very serious, both aspects of this, because we want to make sure that we have a nice, strong communication between the placenta and the myometrium, because that is how the baby communicates with the mom and gets everything that they need from the mom. Now, we can also have, in kind of contrast to this abnormal separation of the placenta, we can also have this abnormal adherence with the placenta. So basically, we want to have the placenta, in terms of the maternal aspect, we never have an abnormal adherence to the baby because the baby is not attached to the placenta, but we do have this abnormal adherence between the placenta and the myometrium, so between the placenta and the mom. Now, we typically want to have the placental tissue, nice border, nice barrier, which is usually going to be decidual tissue, and then the myometrium, right? So that's going to be our normal perfect world. But sometimes the placenta can get a little aggressive, right? And then we don't really have that separation, that decidual tissue to separate. And that's where the placenta is going to start to invade the uterine tissue, the myometrium. That is not good. We don't want that. That's not good for the mom. So now we have three categories of abnormal adherence. We have accreta, increta, and percreta. Accreta is going to be the least severe form of abnormal adherence, and basically it's going to be when we just don't have that border between the two anymore. So it's going to be in direct contact with the myometrium, but it's not going to start to invade it yet. Increta, we're going to start to invade, and percreta is we basically took over the entire myometrium. So now there's no normal uterine tissue left. It's really all placental tissue. Now, with this abnormal adherence, accreta is going to kind of be its little own separate thing that can be kind of treated clinically after delivery. But basically, if we have increta or percreta, the mom has to get a hysterectomy after delivery because there's no more myometrial tissue. It's all placental tissue, and there's really no way to save that uterus. So this is something that is really unfortunate for the moms. It's not really going to have an effect on the baby in that pregnancy, but that's, you know, pretty traumatic for the mom to not only have to go through delivery, but then immediately go through a hysterectomy. So it's pretty unfortunate. Now we can evaluate that on ultrasound. This is going to be when we start to lose that smooth differentiation between the placenta and the myometrium, and everything starts to kind of look like a discrete placenta. That's going to be something that brings it to our attention while we're scanning. So now we also can have some intraplacental lesions. We kind of talked about some of these before. We can have a blood clot in the intervillous space. We can also have placental lakes, which is kind of just like the pooling of venous blood in the placenta. It's not a vessel, right? So when we put color on it, we're not going to see blood flow. It's just going to be blood accumulating. You can also see fibrin deposits. This is going to be same thing, pooling of blood in the subchorionic spaces. So kind of depending on where it is located, we'll be able to differentiate what type of collection this is. And then our intervillous thrombus, where we basically have a blood clot in those intervillous spaces, and that's going to be a common sign of that RH incompatibility. So top left, we have our fibrin deposit. That's going to be right in that subchorionic space, so right underneath that membrane on top of our placenta. This is a good example of a posterior placenta. So here we have our chorion, and then we have our placenta here, and then we have all of that fluid accumulating between the two. That's going to be our fibrin deposit. And then we have our intervillous thrombus, these guys right up here. Again, it's really hard to be able to differentiate these. As long as you're documenting them for the radiologist, totally fine. And then we have our placental lakes occurring on this picture here. So placental lakes, intervillous thrombus or thrombosis, they're going to kind of look very similar to each other. And again, we just want to make sure we're documenting. Okay, moving away from our placenta towards our umbilical cord. Now the anatomy of the umbilical cord, very important to know. The standard umbilical cord has one vein and two smaller arteries, kind of opposite of everything that we've learned so far. The vein is actually going to be supplying oxygenated blood from the placenta, and the arteries are going to be transporting deoxygenated blood to the placenta. So the roles of the arteries and the veins have really flipped in terms of the fetal umbilical cord. The cord itself is going to be surrounded by Wharton's jelly. This is kind of this connective gelatinous tissue that's made up of amniotic cells. The cord itself is going to be 1 to 2 centimeters in diameter, but 40 to 60 centimeters in length. So pretty long for the most part. It should be coiled. We'll talk about the coils in a second. We are going to make sure that we are documenting the umbilical cord with color so that we can evaluate the two arteries and the one vein. We are also documenting the umbilical cord as it inserts into the baby's belly, into their abdomen. And then we are going to document the umbilical arteries traveling adjacent to the fetal bladder with color on as well. So abnormal cord length, like we said, 40 to 60 centimeters. You can have a short cord or a long cord. Short cord is smaller than 35. Long cord is longer than 80. If you have a short cord, we are associating that with restricted space, so IUGR, oligohydramnios, which is not enough amniotic fluid, fetal anomalies, tethering of the cord, so it's getting stuck somewhere, cord compression, so it's getting squished somewhere, and then other sorts of fetal conditions. Long cords are going to be associated with too much amniotic fluid, so polyhydramnios, cord knots, cord compression as well, cord prolapse, stricture, and torsion. So it's kind of really hard to actually measure the length of the umbilical cord. It's not something that we're performing, but if you happen to see a really short umbilical cord, you don't really see a lot of cord free floating in amniotic fluid, we need to kind of question if that's going on. Next, we have cord coiling. This is normal. We should see cord coiling. This is going to be related to fetal movement. So as the baby is flip-flopping around in there, twisting and turning, the cord is going to twist with the baby. The cord can coil up to 40 times. It's typically going to be coiled to the left. If we see coils to the right, it's going to be associated with developmental anomalies. An absence of coiling is also going to be associated with abnormalities as well. So decreased fetal movement is going to be the main thing that is going to present with no coiling. So here you can kind of see it looks like a DNA helix. When we have our color on, we see our 2 arteries and 1 vein. Next, we have cord attachments. So talking about attachments into the baby, but mainly about attachments into the placenta. So the baby's umbilical cord should always insert into the umbilicus of the baby's abdomen. We can sometimes see complications with that cord insertion in terms of anomalies with the baby, which we will learn about in a few weeks. But today we're talking about abnormal cord attachments with the placenta. So it's typically going to insert into the center of the placenta, just like that first picture there, right here. We can kind of see it's going right into the middle, but we can also have abnormal attachments where that placenta does not attach right into the middle. That's going to be our battledore or marginal, and then our velamentous or membranous. So we use the terms battledore and velamentous. We don't really use marginal or membranous. Battledore is going to be when the cord inserts into the edge of the placenta, and then velamentous is going to be when it inserts into the membranes before it inserts into the placenta. If we see a velamentous cord insertion, this is actually going to be associated with a risk of an anomaly with that baby. So this diagram on the right hand side is showing us the velamentous because it is attaching into the membranes before it's attaching into the placenta. Now if it was a battledore, it would be attached here or here. Next, we have single umbilical artery. This is also known as a bivascular cord. This is the most common umbilical cord abnormality, and it is going to be associated with a high risk of anomalies. So a lot of genitourinary anomalies, trisomy 18 and 13, which we'll learn about, cardiovascular anomalies as well, because we don't have the normal arterial and vascular setup like we do with a normal baby, and then omphalocele. So that is going to be a sort of gestational gastrointestinal condition that we will learn about. So basically when we have this, we only have 1 artery and 1 vein instead of 2 arteries and 1 vein. And that's because one of the arteries just kind of shriveled up and died in early development. Typically the left artery is more common to atrophy rather than the right artery. That's not something that you need to be able to identify. That's a registry question that the left degenerates in single umbilical artery cases, but you do need to be aware of how to document that, and that if you are only seeing 1 artery in the umbilical cord, that needs to be brought to immediate attention. Next, we have nuchal cord. This is when the umbilical cord wraps around the baby's neck, and it actually occurs in 20% of all deliveries. So pretty concerning, but a lot of physicians and midwives are equipped to handle that and to untwist that very quickly. We can document that further along in the pregnancy. We can use color Doppler to help determine the location. You know, you could have the cord kind of sitting near the baby's neck, right? It could kind of wrap around the baby's neck, but does it fully wrap all the way around the baby's neck? If it truly wraps all the way around the baby's neck, that's going to be a nuchal cord. It can cause fetal distress as the baby is descending down into the pelvic canal to be born and delivered, and can result in heart deceleration. So of course they're monitoring you very closely when you are in labor. So if they notice any fluctuations in the baby's activity, they're going to intervene immediately. I actually saw a baby that had a nuchal cord twice. So the cord was wrapped around the baby's neck 2 full times. It has a very interesting sort of ultrasound pattern. I'll try to add a picture of it if I can find a good one for you guys. Let me just make a little mental note of that. But it's a lot more common than people think, and the healthcare environment is equipped to handle that. Now we have cord prolapse. This is actually more concerning than nuchal cord, and basically it's when the cord comes out first before the baby. So when we see that cord kind of crossing over the cervical os, we need to be concerned for cord prolapse. And basically the cord is just coming out through the cervical canal, and then the baby will follow it. It's very common with a breech baby, and this is why we don't like to vaginally deliver breech babies for that reason. One, the baby can have a lot of shoulder dislocation when they are born breech, but also the umbilical cord is more likely to come out first. Kind of similar with the placenta previa. If the placenta is coming out first, it's going to result in decreased oxygen to the baby, fetal stress, and heart decelerations as well. So this is going to be very, very emergent. Next, we have vasa previa. So this can kind of precede cord prolapse, where the vasa previa is the cord kind of crossing over the cervical os. You can see in that picture there that we have our umbilical cord crossing over the cervix before the baby would be delivered. So again, we need to be aware of where that cord is positioned. This is going to be caused by a velamentous insertion. So if you have that abnormal cord insertion into the membrane prior to the placenta, that's where we can kind of get this weakening, and then that is going to be kind of crossed over the cervix. It does have a 70% mortality rate because a lot of times it just goes unknown and undiagnosed, and then when they go to deliver the baby, we have that cord prolapse coming out first. Next, we have umbilical vein thrombosis. That's exactly what it sounds like. We got a blood clot in that umbilical vein. Now we only have one vein to supply the baby, right? So we know that that baby's not going to get all of the nutrients and supply that they need. It can be caused by torsion of the cord, knotting, or compression of the cord. It's going to result in stasis, or that blood flow becoming stagnant, so we don't have the natural exchange that the baby needs, and it has a high risk of fetal death because of that. So when you're looking at your umbilical cord, you want to see your two umbilical arteries, your one umbilical vein, but then if all of a sudden in your vein you see this and you don't see any further blood supply coming out, well, you really need to be concerned about what that baby is getting. Umbilical cord knotting. So true knots in the umbilical cord are really rare, and we usually only see them with mono-mono twins. So when we learn about twins, mono-mono means that they share the same of everything. So you have two twins floating around in the same sac with no separation with each other with two umbilical cords. So think about if you had like two shoestrings and you just were constantly crisscrossing them over and over and over again for 10 months, you're going to get an actual knot that occurs in those cords. So we can actually see kind of like the kind of more so like coiling of the umbilical cord in and of itself. So like you can kind of get like this swirl of the umbilical cord. That's going to look like this. That's not really a true knot. This is a true knot. See how now it's looped under itself? And same thing over here, true knot. Okay, moving into our cervix, moving along here. Cervix is very, very important in terms of our responsibilities, especially when the mom is not ready to be in labor yet. So we want to see a nice, long, closed cervix, 3 centimeters in length or longer. We're visualizing this transabdominally with a very full maternal bladder. So moms don't really like us because they always feel like they have to pee, and then we're making them pee, and then we're making them drink, and then we're pushing on their bladder when they also have a baby pushing on their bladder. So becoming proficient in documenting the cervix is really important if you're going to work in the OB world. We are only doing a transvaginal if we are questioning that that cervix is short or that that cervix is open, and we need to get that approved with their provider. So we don't want to cause any extra pressure or stress on the cervix by putting a transvaginal probe in there. Also, if their cervix is open and we put a transvaginal probe in, we run the risk of infection. So we only are doing transvaginal to evaluate the cervix if we truly need to and we see something abnormal on the TA. If the mom just doesn't have a full bladder, we're not going to, and we can't see the cervix, we're not going to do a TV for that. It needs to be clinically necessary. So here we have a beautiful cervix. We have a nice full maternal bladder. We have a baby fetal part. I don't know what this is, probably their little bum. And then we have our vaginal canal, and we have a nice closed cervix. So you're measuring from os to os. So if we take that out, now imagine if the calipers aren't there, right? See how this kind of dips and then dips, right? That's our os. And then see how this kind of dips and dips. That's our external os. So that's what we want to be measuring there. Our cervix is nice and closed. We don't see any fluid accumulating in there. So perfect, nice and healthy. Now, when we don't see that, we need to question, incompetent cervix or insufficient cervix or premature dilation or thinning. So we need to really make sure that we can evaluate that cervix at least 3 centimeters long and closed. Now, we hear the terms dilation very frequently, which I'm sure you have heard of at some point, but then we also need to be aware of the term effacement. So dilation means the spreading of the cervix, so the cervix is opening, but then the effacement means that it is thinning. So the cervix itself, if we go back here, right, we care about the length like we just measured, but then we also care about the thickness, right? As that cervix dilates, it's going to start to thin out and spread out, and we'll take a look at what that looks like. So basically, when we have an incompetent cervix, it's the inability of that cervix to kind of stay closed, and it now kind of runs the risk of having premature labor, and then all of the membranes can kind of come out a little bit earlier. We can have our water break a lot earlier. So it's going to be a common thing with the second trimester abortion. That's really the only time we see anything kind of going wrong with spontaneous abortions in the second trimester, is because either that cervix isn't working or we have any sort of these extrafetal assessment abnormalities. So we have a placenta abnormality, a cord abnormality, a cervix abnormality. That's really going to be kind of the only place where these complications come from. It's going to be associated with the previous cervical trauma, so that could even be a previous C-section, because that's where we actually cut for the baby, right at that lower uterine segment. Any other sort of cervical procedure, so maybe you had cervical cancer or atypical cells and we needed to get rid of that. We needed to do a LEAP procedure on you. That can result in your cervix not being fully strong enough to support the pregnancy. Sometimes, depending on how far along you are and depending on how severe the incompetent cervix is, we can perform a cerclage, where we basically go in and we stitch the cervix closed until it's ready for you to deliver. And on ultrasound, we're looking for shortening, we're looking for dilation, and we're looking for bulging of the membranes. Dilation is going to be the best sign for us to diagnose incompetent cervix. Bulging of the membranes, not really as much, because sometimes we can't evaluate the actual echogenic membrane that well. So shortening and dilation are going to be what we are looking for. Again, if we're seeing anything abnormal, we are requesting to perform a transvag. We are not going and performing a transvag. We are requesting to perform it. We're bringing it to our radiologist, we're bringing it to our physician, and we're saying, hey, this is what their cervix looks like. Would you like me to do a transvaginal? And they can weigh those options. So there's an acronym called Trust Your Vaginal Ultrasound, and that's going to help you kind of determine how severe the incompetent cervix is. So you're going by the shape, right? You're going by TYVU. Now, T is going to be this top left picture. So we're starting to see some dilation and shortening in that cervix, because now we're seeing some fluid in that cervical canal, right? So our cervix is making a T shape with its dilation, right? Our next one is going to be Y. So here we have our Y shape. So now we're kind of spreading a little bit more with our cervical internal os than we were with the T, but we're not really shortening too much yet. We're not really thinning too much. Now we get into the V and the U, and now this is where we get a lot of effacement. So here we have our V, and we have all of that dilation, allowing all of those membranes and all of that fluid to come in. And now basically our cervix, the only portion of our cervix that is still closed is right here. So that's going to be really kind of thin, right? That's definitely not going to be 3 centimeters in length. And then we have our U. So this is really bad. So we have totally dilated. We've totally thinned out. So see how, like, when we go back to T, here's our, I'm going to use a different color. We go, hold on. We have cervical tissue. Same thing with the Y, cervical tissue. But then when we look at our U, look how thin that cervical tissue is, right? And then down, kind of looking at what is still closed, we only have this. So that's probably going to be like 5 millimeters, to be honest. So we want a normal 3 centimeter in length cervix. This is going to show the progression of how severe that incontinent cervix can become. Okay, next we have our amniotic fluid. We're just going to finish off with this. This is going to be produced, this is, the necessary fluid that the baby needs to survive, right? And this is what is going to protect the baby. This is what the baby's going to practice breathing with. This is what the baby's going to practice swallowing with. So the amniotic fluid is very, very important, and we can actually tell a lot by the amniotic fluid. It's going to be produced by the umbilical cord, interesting, the membranes, the baby's lungs, skin, and kidneys. So a lot of structures that you probably didn't think would be responsible for producing fluid. Kidneys make a lot of sense. Lungs kind of make a lot of sense, but all of the other structures a little bit abstract. Now, fetal production of amniotic fluid is going to kind of begin around 8 to 11 weeks, and then by the end of week 20, the majority of that amniotic fluid is going to be produced by the baby's kidneys, because now the baby is swallowing, kidneys are filtering, the baby's peeing it out, and the baby's swallowing again, kidneys are filtering it, and the baby's peeing it out. So if you want to think about it in one way, the baby is basically swallowing their pee for the rest of the pregnancy. So it starts really early, and then by the end of week 20, the main production of amniotic fluid is going to be from those kidneys. So the function of the amniotic fluid, yes, it's going to serve as a cushion for the baby, gives us nice protection. It allows for the baby to move in there, to practice stretching, practice breathing, practice swallowing. It's going to, actually maintain the temperature of the baby. So even if the mom is really hot or really cold, the baby is going to kind of be exposed to this kind of continuous temperature throughout. And it's also going to allow for symmetric growth of the baby. So basically the baby can kind of grow and develop as much as they necessarily need to, and it's going to provide space for that baby to do so. So now the amniotic fluid index, also known as AFI, is very important for us to perform because it gives us an idea of how much fluid that baby has. So we do it kind of in the sense of like the ascites check for a paracentesis, but we need to be a lot more precise. Fluid, like we said, is going to start in the first trimester, but then it's really going to kind of ramp up in that second trimester. So it's going to kind of, increase pretty rapidly in that second trimester. By the third trimester, end of pregnancy, we're not really going to see any variations to the fluid unless there's something wrong. When we're doing an AFI, we're doing it in quadrants. So we want to make sure that we're documenting all 4 quadrants, not of the mom, but of the baby's amniotic sac. So when we're scanning around the mom, we want to make sure that we're not kind of overlapping pockets. And if you don't see fluid in a pocket, then you don't measure it, right? So we don't want to overestimate, we don't want to underestimate. And when we're doing the 4 quadrants, we're actually using a quad screen. So I'll show you guys how to do that in the lab, where you can get 4 views to come up on one image. And then we're doing AP diameters of each quadrant. You want to make sure that you have your color Doppler on the quadrants, on the fluid, so that you're proving that there's no vessel in the fluid. You also want to make sure that there is no fetal parts in the fluid, so you don't want a little finger in the measurement that you're taking. You don't want their little bum in the picture that you're taking. So you want to make sure that the pocket is kind of clear and empty. And then we also can do that, the 4 quadrants is for the AFI, but we can also do an MVP, and this is the max vertical pocket. So you could find the largest pocket, and you could do 1 AP measurement of that biggest pocket. If you are doing an MVP, your measurement should be within 2 to 8 centimeters, again, depending on the gestational age. And then let's talk about just our AFI. So our 4 quadrants, again, of the sac, not of the mom. We also want to make sure that there's no crowding, like we said, so no fetal parts or no umbilical cord. We're putting color on, so this picture wouldn't pass at women and infants. You need to put color on to prove that there's no cord there. And our fluid should be anechoic. We sometimes can see a little bit of echogenic debris floating around, but we don't want to see the whole pocket like totally echogenic, right? So a little bit of debris in one of the pockets is totally fine. Now we're measuring just the fluid. So if you look at these pictures here, like this is going to be membrane up here, so we don't want to include that. This is placenta in this picture, so we don't want to include that, right? Same thing, membrane up here, placenta over here. So we're just measuring the pockets, okay? We want to make sure we have color on. We are measuring directly vertical, anterior to posterior, no fetal parts in the pocket. So what happens if we have too much fluid or not enough fluid? That's when we get into the polyhydramnios or the oligohydramnios. So if we see way too much fluid, or we see one pocket that's like woof massive, like this one right here, they just did an MVP and they got 11 centimeters. Like, that's really big. We just said that it should be 2 to 8. So this baby has poly. So basically we can kind of categorize it in terms of mild, moderate, and severe. So if your MVP is 8 to 12, that's going to be mild poly, moderate 12 to 16, and severe anything greater than 16. Now imagine like how large that belly would be, right? How big that uterus would be with all of that excessive fluid in there. It can lead to preterm labor because it's going to kind of trick the placenta and trick the baby into thinking that, like, okay, they're so developed and they've been hanging out for so long because there's so much fluid that, they're ready to go. In reality, they're not. It's going to be caused by gestational diabetes, RH incompatibility, central nervous system and gastrointestinal anomalies, facial clefts and masses, fetal hydrops, twin-to-twin transfusion syndrome, which we will learn about, and skeletal anomalies. So the skeletal anomalies, that's going to be kind of back to that cellular level that we'll learn about. Fetal hydrops we're going to learn about as well. Gestational diabetes, RH incompatibility, those are all processing disorders. So that placenta is going to kind of play a role in this polyhydramnios development. And then if you think about facial clefts and masses, if the baby is responsible for processing and filtering fluid for the majority of the AFI, then if you have a facial cleft, can the baby swallow as well? Or if there's a facial mass, can the baby swallow as well? No. So they're not taking in any of this amniotic fluid to be filtered and processed. So instead, it's just kind of hanging out and it's just accumulating. So all of these kind of have their own rhyme and reason. Next, we have oligohydramnios. So there's not enough fluid. This is when we have an AFI of smaller than 5 centimeters, also an MVP of smaller than 2. So this is really like there's like no fluid in there for these babies. So it's really going to be associated with fetal demise, renal abnormalities. So if the baby doesn't have kidneys, they're not really going to produce any amniotic fluid. I mean, we can't rely on the skin, the lungs, the cord to produce the fluid when the main driving factor of fluid production is the kidneys. IUGR, these babies are going to be really, really small. The baby is going to potentially have premature rupture of membranes because there's just really no fluid to kind of associate with the membranes. And then we can also have anhydramnios, and this is when there's absolutely no amniotic fluid, and chances are that baby is stillborn. So you don't really want to have either of these, but the best outcome would be to have polyhydramnios. It's kind of better to have more than not have enough. And the reasons for polyhydramnios can be a little bit more treatable than oligohydramnios. So that is it for this PowerPoint. A lot of information on here. We are going to come back to a lot of this. We are going to be talking about oligohydramnios, polyhydramnios, pretty much for the rest of the semester. We're going to be talking about, a lot of the RH incompatibility, the gestational diabetes. We're going to be talking about all of that as we go throughout the semester. So a lot of new information, a lot of abstract information. And if you have any questions, please ask.